Okay. Welcome to coexisting again with me, at least. The next several weeks, we're going to be reviewing the GI tract, all the GI system, pretty much go into kidney, go into electrolyte problems. That'll be all put on the actual website, up to date. All these slides have been updated. If you see the previous lecture, I've changed things quite a bit. So, trying to make it understandable and try to keep it all compacted so you guys really get something that you can really use in clinical. I've taken out a lot of slides that I thought were unnecessary or not what you would need. So, and then I put in things that I thought were more relevant to what you need to know. Okay. The first discussion we're going to have is we're going to cover the liver and the biliary tract. And believe it or not, this is an area that we work with pretty constantly. We're taking gallbladders out all the time, and you really need to know the complications, and you need to know what the liver does as a job. So let's go first into the actual anatomy. This is kind of a little quick overview. The liver is basically two lobes. The right lobe is much larger than the left lobe, and it's separated by a ligament called the falciform ligament. The falciform ligament has included in it the actual remnants of the ductus venosum. It becomes a ligamentum venosum. So the falciform ligament and the ligamentum venosum all sort of become one. Okay? If you look at the actual surface of the liver, it should be smooth. Should have like an orange texture to it, or orange-pink texture to it, which is normal. And it should not be nodular in appearance. And we'll show that a little later on when we show cirrhosis. The main blood supplies to it are, of course, venous and arterial. You have a main arterial branch called the hepatic artery. And the hepatic artery originates from the aorta. Okay, a portion of the aortic, the gastric artery, the celiac artery is the originating the originating artery from the aorta that eventually branches into the hepatic artery. Okay, so that's pretty high up. It's right below the diaphragm, and eventually leads to the arterial blood supply to the liver. But that's not the main source. Well, it's part of the main source of oxygen, but it's not the only source of oxygen. That's very important for you to know. Okay, it only provides around 50% of the oxygen supply to the liver. The other blood supply to the liver that it not only does two things is the portal vein. The portal vein is what also provides oxygen to the liver, but also provides all the nutritional support from the GI tract. So all the stuff that your stomach and your small intestine pick up gets transferred into the portal circulation, and then the liver processes it. Okay, so the liver does a very important thing. It's going to take all that food that's coming through the portal vein and break it down to something usable. It's going to break down any toxins that you've absorbed so it doesn't get to your brain. Even our medications that we give to a patient, it goes through the vein, goes through the pulmonary circulation, and then it goes to the brain right away, yes, but then part of it will then go through the liver, and by the time it comes back again, it'll be broken down by the liver. But that's why medications work so fast, because they bypass the liver on their first pass. On the second pass, though, they get broken down by it. Okay? The blood supply to the liver is 50% of the oxygen supplies from the hepatic artery. And this is one of the few organs in your body that is not 100% supplied by arterial. But this one is actually supplied by an additional 50% of the oxygen supplied by the portal vein. Okay? If you look at the actual percentage of blood going through here, though, is that the portal vein is a huge amount of volume going through it. Okay? It actually has 75% of the volume being delivered to the liver is not artery, but it's actually vein. Okay? Now, why is that statement important? For one thing is, if you get a portal vein injury, it tends to be catastrophic and lethal to most individuals. If the surgeon's working in that area and he hits the portal vein, it's a nightmare because all you'll see is the blood will just start to rise in the abdomen, and you can't tell where it's bleeding from. There's no pulsation. Okay, arterial bleeds are actually easy to find most of the time because you'll see it squirting out, so it sort of indicates to you where it's at. But when you hit big veins like the inferior vena cava, which is retroperitoneal, which just sort of helps, but the portal vein is not retroperitoneal. If you injure that guy, you're going to get massive amount of hemorrhaging, and you won't be able to locate where the source is at. The function of the hepatic artery is that it brings the stuff that systemically your left ventricle is now pumping out. A certain percentage of it will then send material through the liver, which basically clears toxins that are already in your bloodstream on the arterial side. But the digestive component, which is in the portal vein, it clears toxins. It also clears bacteria, and it also begins to break down the nutrients to make them usable for the rest of the body. Now, here's what I want you to understand how the portal circulation is originating. The portal circulation is the venous system, okay, of the actual small bowel as well as the large bowel. Eventually, it all combines and forms a very large portal vein, which then goes into the liver. Okay? That portal vein will then distribute blood to different portions of the liver, and then it will eventually come back together after it passes through sinusoids into the actual inferior vena cava after it goes into the hepatic veins. So your portal vein eventually forms into the inferior vena cava once again, a branch of it. Okay? Remember, the inferior vena cava is the one that's coming back from the lower extremities, so it's providing returning blood to the heart, but the hepatic vein eventually join up to the inferior vena cava and allows all this fluid from the blood from the digestive tract to come back towards the heart. Okay? The reason to understand this anatomy is that, unfortunately, from different disease processes, you can get sclerosis or damaging of these blood vessels, and what it causes basically is a damming effect. Okay? So the portal circulation basically begins to grossly enlarge. Okay? Because if you put a dam across here, let's say we do this, and put a dam there, okay? Everything behind that is going to engorge. Okay? And this is what happens to patients that develop cirrhosis. Okay? So you get portal engorgement. Well, that portal engorgement will include gastric veins. It will also include veins that eventually join up to the gastric veins, which are the esophageal veins. So you get esophageal varices, gastric varices. Okay? You also get fluid that now accumulates inside the peritoneal space, which you call ascites. So all these things that you see in severely cirrhotic patients are due to the actual occlusion or partial occlusion of the portal circulation. Okay? All the stuff that you eat, basically, after it passes through your stomach, where really very small amount of fluid is absorbed through the stomach, because most of the stuff is just being broken down there. pH is very low at that point. With a low pH, it begins to break down most of the complex proteins and fats. And most absorption, because of large surface area, is actually taking place in the small intestine. Okay? Once that material comes passed through, it then gets digested and worked on by the liver. So fats, proteins, and sugars are all part of the job of the liver to manage. What's interesting, too, is that there's specialized cells in the liver that actually clear, they're basically giant macrophages, that clear bacteria. Okay, and that's very important because bacteria getting systemically, of course, causes endocarditis and causes other problems like sepsis. So the liver has a very good job of clearing a lot of bacteria that can be absorbed through the GI tract. And the liver also clears the toxins. So if you do anything to this system where you bypass the liver, you can actually get accumulation of toxins as well as you can increase the risk of developing a bacteremia. What kind of procedure do we actually bypass the liver? TIPS procedure. Good. TIPS procedure, and I'll talk about that a little later. TIPS procedure actually connects up the inferior vena cava to the portal circulation, bypassing a large portion of the liver. And as a consequence, these people don't die of hemorrhaging to death, which is why we're doing it, but instead they die of encephalopathy or bacteremias. Okay? So you're just changing the way they actually die. Now, when you look at the cellular level, the hepatic lobule, you have the portal circulation comes in, and then it goes in through these sinusoids. These are large areas that have hepatocytes, which are specialized cells that do all this digestive work. Okay? Eventually, they form into the central veins, and the central veins eventually unite to form the hepatic veins and then returns to the IVC. Okay? As the blood travels through here, these liver cells have a very large surface area to do what they need to do. Usually they convert molecules to make them into smaller building blocks. They make them usable, and they deactivate a lot of compounds that actually are very dangerous. Eventually, you get removal via blood to the kidney for water-soluble compounds. But the other thing that the liver is able to do as well is that it's able to transfer lipid-soluble material, okay, into bile. So fat-soluble material gets removed via the bile duct. Okay, so it's a mechanism to get rid of stuff as well. So the bile duct is a very useful mechanism to remove toxins, as well as providing material that helps break down a fat. And that's why you have your gallbladder system. One of the things that you need to understand a little bit is the bilirubin metabolism. When the red blood cell breaks down, it breaks down into hemoglobin. Hemoglobin then breaks down into two components, heme, which is, if you look at the heme molecule itself, it's a pigment. Okay? It is what contains the iron in it, and it also has the actual color in it, which is called biliverdin. Okay? And the globulin is actually a protein. It's amino acid eventually gets broken down and becomes a part of the amino acid pool. The biliverdin is actually a very difficult compound to break down. Okay? It becomes usually the unconjugated bilirubin is lipid soluble. Okay? So the kidney is going to have almost an impossible time to get rid of it, right? If it's lipid soluble, it goes through the liver, filters easily, but it gets reabsorbed very rapidly back. So you really have to make it a water-soluble compound. Okay? But the unconjugated, which is very important for you to know, unconjugated bilirubin, okay, means it hasn't been converted into a water-soluble compound. That's how you say it's unconjugated. It's it's still lipid soluble. Okay? The unconjugated bilirubin binds to albumin, and it gets eventually back to the kidney, and eventually comes back to the liver again, where it becomes conjugated, okay, and makes it a water-soluble compound. Okay? Some of the conjugated bilirubin will go into bile, okay, which then is removed. It's put into the intestinal tract, and once it reaches your stool, bacteria convert it into urobilinogen, okay, and that's what gives the actual color to your stool. Okay, if you don't have bile working properly, what you'll see is that the stool will not be its normal color. It'll actually get lighter, and if you actually have no bile at all being produced, or you have a deficiency in it, your stool will end up turning more whitish in appearance because the fats cannot be broken down properly. Okay? The reason we teach you about the bile pathway is that you're going to be doing gallbladder operations in the anesthetic point of view, and you have to know the complications of what can happen if something goes wrong. The normal procedure for removing a gallbladder is to identify what's called the cystic duct, which is the actual duct that comes from the common bile duct that attaches to the gallbladder. The incision or clamp is put across the cystic duct, and then the gallbladder is removed intact. Okay? And at that point, you still have an intact common bile duct that connects the liver to the intestinal tract. That's what you want. And sometimes, surgically, there'll be mistakes made where the common bile duct will be cut. That is a disaster. Okay? And the reason for it's a disaster is because you take the bile pathway and you eliminate it. So now bile cannot be removed via the liver. It starts accumulating in your bloodstream, and you get all sorts of big problems. The content of bile, though, is that it contains cholesterol, neutral fats, phospholipids, and electrolytes. And this is a reason why we develop gallbladder disease. If you take in a large amount of cholesterol in your diet, or you're taking a lot of neutral fats that are not saturated fats and highlights high amounts of phospholipids, or you go into a very radical diet, or you get put on statins, which basically begin to eliminate a lot more fat than your body would normally uptake, then it concentrates in the bile at very high concentrations, and it becomes like a crystallization process. It will start developing literally little crystals inside your gallbladder, and it eventually forms a stone. Okay? So you can have diseases where you have cholesterol and neutral fats and all those things forming that. The other thing that's besides the content of that is bile salts. These are derivatives from cholesterol. They emulsify fats, and they're very important for part of the enterohepatic circulation for bile salts to be reprocessed. They are reabsorbed most of the time, these bile salts, in the small, in distal small intestine. The liver then goes via the hepatic portal vein, and it's re-secreted as bile. So this is being constantly reused. So bile salts don't tend to be wasted. Bile pigment, on the other hand, you do want to remove it. You want to get rid of it. It's a byproduct of course, hemoglobin synthesis, we talked about. And it's conjugated bilirubin that you are getting rid of. Okay? The urobilinogen is what causes the dark coloration in your feces. That is processed by bacteria. So, is there any way that our GI tract doesn't have any bacteria in it? The answer is no. Okay, under normal circumstances, that would not be the case. If you give somebody an overabundance of high doses of antibiotics, okay, and you effectively kill all the bacteria in their intestinal tract, it causes a problem in the sense that the conjugated bilirubin that's in the stool does not get converted, and the actual stool will begin to change its coloration as well into more of a reddish color, okay, which is not a good sign. It would indicate that your bacterial normal flora has been wiped out. Okay? Usually following that, you see severe forms of diarrhea because usually the pathogens are the ones that are resistant to antibiotics begin to survive, and the person can have severe problems with the intestinal tract. And we'll talk about that a little later on. But I want you to sort of look at the anatomy here. This is the common bile duct that's coming down off the liver, and the cystic duct is right here. This is what's connected up to the liver, to the gallbladder itself. And the surgeon identifies this area and cuts it and removes the gallbladder when we're doing a cholecystectomy. This is what enterohepatic circulation of bile salts is basically doing. It's indicating to you that it's being reused constantly and it's not being wasted. You can spend a little time looking this over just to make sure that you understand that bile salts are really not wasted very much. The normal laboratory test that you should have when you're looking at liver function is you've got to know several things. Liver produces things, and it also breaks down things. So for a healthy liver, you need to be able to identify if it's producing certain amounts of proteins. The most important protein that the liver produces is albumin. Okay? So one of the things that we check is albumin levels. Okay? That indicates to you that the metabolic factories of the liver are functioning properly, and the nutrition that the person is receiving is adequate for the enterocytes, the hepatocytes, to do their job. The second thing is an indicator of how the liver is doing its job of breaking down compounds. Okay, it's very easy to pick up bilirubin because we pretty much know that the hemoglobin is made at a constant rate, and we also have a constant rate of breakdown of hemoglobin. So bilirubin, to have a steady state of it, would make sense that you should keep it around 1.1 milligrams per deciliter. It's not very much, okay? But your body's doing a very good job of removing it. Now, if you see that number become elevated, okay, and this is where it becomes important to know why the mechanism unconjugated versus conjugated means, okay? If you see that somebody's bilirubin is beginning to rise, the next test that we look at is it unconjugated or conjugated bilirubin, okay? If you see that your unconjugated bilirubin is going up, okay, but your conjugated portion is not, okay, that means that there's something wrong with the way of actually it converting the unconjugated lipid-soluble material to a conjugated fashion. Okay, so it could be a disease process. in the liver itself. Okay? If you have, on the other hand, conjugated rises, it will usually indicate to you that your biliary tract is obstructed. Okay? Because conjugated is actually made by the hepatocytes, but now they're removed via the bile. Okay? And if you cross-clamp the bile and you see conjugated levels rise, that would indicate to you that your liver is having an occlusion in the biliary tract. Now, for actual cell function or cell injury, which occurs like in hepatitis of any kind, and hepatitis is a generalized term. It just means inflammation in the liver. That's all it means. It could be an infectious, it could be a chemical, it could have many different sources to the actual inflammation. But when you see disruption of the cells, the main one of the main molecules that are inside the cells are SGOT, or aspartate aminotransferase, or alanine aminotransferase. Those are pretty important enzymes that are found inside the hepatocytes that will indicate to you damage. Alkaline phosphatase will also be elevated, and prothrombin time, which is a production of the actual compounds to make your clotting cascade, will also be damaged, and you'll see an elevation of that as well. So PT is an indication of liver disease. So if you have hepatobiliary mechanisms, you look at the intrahepatic obstructive jaundice. Okay, so this is somebody that has jaundice from intrahepatic injury, and you have hepatocellular damage. You see decreased liver ability to excrete bilirubin, and you get conjugated and unconjugated hyperbilirubinemia. If you see the actual hematological injuries, let's say you have a massive amounts of hemolysis taking place, then the liver cannot break this stuff down. It can't conjugate it fast enough, so you get unconjugated hyperbilirubinemia, which would indicate to you it's either extrahepatic injury, things like that. Versus if you see the bile duct obstruction, this is what I was telling you here, the conjugated hyperbilirubinemia is much more important. That's really what gets very, very, very elevated. And why would you care for this? Well, if you're having to take care of somebody who has a common bile duct injury after surgery, that means that's going to go from a very relatively minor procedure, which is a gallbladder operation, okay, into a major procedure of trying to fix that problem, okay? And that liver could be in shock in the process. So that person could do really poorly depending on how you deliver the anesthetic, okay? So one of the things you want to look at if post-operatively you're having problems, look at the conjugated bilirubin. If that's really becoming elevated, it indicates that the surgeon's done something inadvertently. Unconjugated, prehepatic. Conjugated is posthepatic, and that's part of the discussion. Now, what you'll pick up on somebody is to see usually their eyes. You'll see sclera icterus. Okay, you see the yellowing. Okay, that indicates to you that the bilirubin is not being properly removed. Okay, it indicates hyperbilirubinemia of some type. Then you've got to figure out which one it is. It's conjugated or unconjugated. Now, the most common causes of most of these processes is where you get elevations and damage is from hepatitis. And the ones that we worry about the most is viral hepatitis. One of the things that we have, at least you guys have, is that you're all up to date on your hepatitis shots. Okay? When I first started, we did not have shots against hepatitis C or D. Okay? So we were sort of at very considerable risk. Okay? The things that scared us mostly is hepatitis B as well. We didn't have shots for that either at the time. So the risk of actually of an anesthesiologist or a nurse anesthetist converting and getting active hepatitis was about 50% by the time you finish your career. It's bad. You can think about that, okay? And a lot of people got liver cancer from it as well. Okay, the good thing is you want to keep up with your shots and keep yourself so you don't get this stuff, and always be very careful with blood products. The good thing is the blood products are a lot safer than they used to be, and for that reason, that also has decreased the incidence of exposure for us as well. But to me, if I had to worry about which one is more risky to me, hepatitis versus HIV, at that time, hepatitis is much scarier because just a droplet gets on your skin, you'll get infected. It does not take much. Versus HIV, you can get blood on you, and as long as you don't have any open sores or have any, you really won't get infected. Okay, but viral hepatitis, on the other hand, is very, very dangerous. CMV infections also can cause viral hepatitis, and Epstein-Barr virus can also cause acute hepatitis. Hepatitis A is 50% of all cases. It's usually from eating contaminated food. Usually it's from oyster beds that have been exposed to sewage, okay, from somebody who has prior hepatitis A. The bad thing is you eat this stuff and you don't know that you have it for 20 to 37 days. So you have an incubation period that's quite prolonged. During that time, you begin to release these viruses into the environment. So, if you don't have a good system of septic system and clearance, you can, contaminate other people very easily. You get an elevation in IgM and IgG, which is the body's way of fighting the infection. And hepatitis A is usually only acute. It doesn't become chronic. And it has a very low mortality, thank goodness, of less than 0.2%. This is what shows you that you get the infection, months in exposure, so you got a little bit of time. You can see that you got hepatitis A, it goes into your stool before your actual antibodies begin to form. Once the antibodies form, that's when you develop symptoms. Why? Why don't you get symptoms? Look at the viral load. The viral load's going skyrocketing upwards, right? That means it's being produced. Okay. Do you guys know very much about viruses? Do you ever take virology, and any of you, or you sort of don't really know what viruses do? Okay. Basically, viruses enter your cell. Okay. They hijack your DNA. Okay. They splice themselves into it, and then they get reprocessed. They steal the protein factories, and they begin to produce their own cells again within your cells. At that point, then they get released into the environment. Okay? And once they get released into the environment, they infect other cells, and it keeps accumulating in your body. Okay? But most of the time, you don't have symptoms because your body is not able to really internally fight itself. What it does eventually is that the IgM and IgGs, especially the IgM, identifies a surface marker on that cell that's been infected and says to it, hey, you got a problem, we're going to kill you. Okay? And they kill it. Okay? So if your liver is fully infested with this virus, it'll kill the whole liver at one blow. Okay? And that's called fulminant hepatitis, which we'll talk about in B and C, and that'll kill you. Okay? Versus hepatitis A, because its virulence rate's not as high, it is producing virus load, but it's not hitting all the cells at the same time. So when the IgM kicks in, it's going to make you sick, okay, because it's going to knock out a certain portion of the liver, but it's not going to kill the whole liver. And that's why the mortality rate's only like 0.2. It does give you symptoms once the IgM begins to attack because it begins to destroy hepatocytes, and it destroys different cells in your body. Okay? Eventually you get jaundice, and you get elevation in LAT, and after the IgM begins to fall, that's usually an indication of acute disease. Okay? So IgM is a disease of acuteness, and IgG is prolonged, okay, immunity. Okay, so if you get re-exposed to hepatitis A, guess what happens to that virus? It gets wiped out almost immediately. So your re-exposure to hepatitis A, you're not going to get it again. Okay? So, and if you think about this in the sense of immunological protection of people, we don't care about IgM most of the time because that's only going to take care of somebody acutely. We want their system to have IgG activation, and we want to keep it IgG activation for the rest of their life. If you only have IgM positive and you don't have any IgG, you're not going to be protected for very long. Okay, so you want to convert into an IgG process. This is what you normally see at the fecal oral route. Okay, nice open sewages. Like in Haiti right now, it's got a huge problem because they have open sewages. So, not a good thing. As for acute viral hepatitis B is much more concerning. 35% of the actual hepatitis is due to this. It has a much longer incubation period of 60 to 110 days. It has hemoglobin S antigens and anti-hemoglobin C persistent carriers. And you see that these people will develop into a chronicity. Okay, some people are carriers, which is bad news because they don't show any symptoms. Okay, but the ones that are eventually become into big problems are the ones that have chronicity, okay, which occurs in about 1 to 5% adults. And if you get it as a kid, it becomes chronic in 80, 90%. Okay? The reason chronic hepatitis B is so bad is that it eventually forms into hepatocellular cancer. And so you're really trying to avoid getting chronic hepatitis B. This is a serology again, shows you the prolongation. And what you're seeing here is these are the actual markers for the actual virus. Okay? We have antigens that we call the HBV, DNA, HBs antigen, which is a serum. The way you want to think about it is if you take the virus and you were actually to take it apart and call it component A, S, or something, the virologists have different names for different components. Usually it stands for envelope, which is the actual covering of the virus. And then the DNA, of course, is the component inside it. So it's a DNA virus versus an RNA virus. And then you have S, usually means inside the surface antigen, which is like a small protein that's embedded in the envelope. So all these things are peaking initially. Then the person gets IgM, which then attacks the liver. And the person develops acute symptoms and eventually forms the IgG process, which gives you the recovery and immunity to re-exposure. If you have chronic disease process, the IgGs don't climb as high. They stay much lower. And as a consequence, you never are able to get rid of the disease process. Hepatitis C is 15%, which is bloodborne. We used to call it non-A, non-B, okay? But now we have the name for hepatitis C because we didn't know there was also a D at that point, so now we have C and D, okay? This one has a short incubation period of 35 to 70 days, and the main marker is anti-HCV, which is hepatitis C virus. Chronic liver disease occurs in 85%, and that many of them develop into full-blown cirrhosis. And this is the ones that we were afraid of the most because this one we couldn't test for when I was training. You just knew it was called non-A, non-B. That was it. We've gotten a lot better at being able to identify this stuff, which is good. And this one also forms into hepatocellular carcinoma. Hepatitis D is rare. It is bloodborne as well. It has a 60-day incubation, and it won't infect you unless you're infected with hepatitis B as well. If it doesn't have a co-host, like hepatitis B, it doesn't really cause much of a problem. The other kinds of viral hepatitis you got to think about are CMV and EBV, especially in transplant patients, is the ones you have to worry about mostly. EBV, if it's usually it's mild and rarely fatal, and it's the same thing you see in infectious mononucleosis, whether that's what EBV virus infections are. Signs and symptoms that you see with viral hepatitis is that your urine begins to turn dark because the conjugated bilirubin may begin to accumulate and it saturates and eventually starts being removed, even though it's lipid soluble. Fatigue, anorexia is evident because your body can't get rid of a lot of toxins and you're not producing enough essential nutrients for the body. A lot of times you'll get, of course, fever from the immune reaction. Patients will get emesis, especially if they take in fatty foods. Headaches, abdominal pain, acolic stools, which means that their stools turn white, is what you tend to see again because your bile is not being produced properly from the inflammation. The lab tests always indicate that you have cellular damage. So you have ASTs and ALTs increase dramatically. The severity of the disease will be sort of dictated by how high the ASTs and ALT levels rise. If they're in the thousands, that may be fulminant hepatitis and that patient may die on you. Okay? Putting these people to sleep has very high risk. This is what you'll see this is kind of a nice little table showing you the actual everything sort of put together for you. Okay? course of the disease is sort of the important ones. Chronic liver disease is B and C. That's the ones you have to worry about the most. Prevention after exposure is usually hepatitis B vaccine. We also have the hepatitis C vaccine, of course, now, interferon. And mortality rate is still not very high for most of these disease processes, but in the long term, that's what you have to worry about when it goes into hepatocellular carcinoma. That has a much higher mortality rate. You can also have drug-induced hepatitis, and that's something you have to learn as well because of our drugs that we give. Most of these drugs are re-exposure phenomena. Okay? These are molecules that the liver, for some reason, cannot process properly, and then when it gets re-exposed to it, the body either causes an immune reaction to take place, and the body begins to attack it like a viral hepatitis. Analgesics can do this. Volatile anesthetics, specifically halothane, was a big causer of drug-induced hepatitis. Antibiotics, antihypertensives, anticonvulsants, and tranquilizers. They tend to be idiosyncratic and they're unpredictable and not dose-dependent. But it's important not to forget about this because if you discontinue the drug, you can get progressive hepatitis and even death. So volatile anesthetics, especially halothane, got a really bad press because of the re-exposure problems that they were having with it. So halothane-induced hepatitis occurs in genetically susceptible individuals. We know that for sure. Okay, so it's not going to happen to everybody. That's why we weren't seeing it in everybody. Halothane is metabolized to what's called trifluoroacetyl halide. This halide binds to microsomal proteins in the surface of hepatocytes. So that's what makes it think that it's a viral, almost like a viral infection. Okay, now it's got that cell now has a surface marker that it didn't have before. This is called a neoantigen. Okay, IgG anti-trifluoroacetyl antibodies are directed against the microsomal proteins on the surface of the hepatocytes, and these antibodies attack this and basically destroys these cells. Okay, so it becomes an autoimmune hepatitis. Okay, so it is an immune-mediated mechanism in somebody who's genetically susceptible. Okay. This is a very nice overall view of what it is for conversion of halothane to trifluoroacetic acid. Now, why is it that our new agents don't do this? The greater amount of fluorination you put on a molecule, the more stable it becomes. So it tends not to break down like halothane did. Halothane had bromide in it and chloride, and it had one free hydrogen that made it very easy to metabolize by the liver. Okay? The newer agents have a lot more fluoride in it. Okay? And as a consequence, you may get fluorination problems, but it doesn't break down into a more complex molecule. Okay? You can see how it forms a free radical, and eventually some of it is formed into other kinds of compounds that can become surface markers and become a problem. The actual metabolism of halothane is around 17%, so it's actually fairly significant for a volatile anesthetic. Most of our volatile anesthetics now metabolize at less than 1%. That's pretty good. Enfurane, isoflurane, and desflurane can form trifluoroacetyl metabolites resulting in cross-sensitivity with halothane. However, the incidence of hepatitis after these anesthetics is much lower than after halothane because the degree of anesthetic metabolism is less than, like I said, 1%. SIBO does undergo metabolism to trifluoroacetyl-related metabolites, but it does not produce immune-mediated hepatotoxicity, which is good. The problem with it is it does form fluoride, and that's one of the issues that we talk about when we talk about possible kidney problems. It doesn't attack the liver, but attacks possibly the kidney. So SIBO may be one of those agents that you have somebody who's renal insufficiency or who has got early stages of renal failure. Should you really avoid? My answer is, yeah, you should try to avoid that. It would not be my most best choice at that point. I would use either furane or I would use desflurane. Okay? So do I have enough to back that up in studies? And the answer is no. A lot of it's theoretical, but if it's theoretical, it's possible, so I'm going to try to avoid it in certain individuals. Okay? If I have another agent. Other metabolites, you can see, look at isoflurane, it's metabolized at 0.2. Desflurane is 0.02 metabolism. Nitrous oxide, look at the metabolism on that sucker, 0.004. Okay? But I'll show you something that sometimes metabolism doesn't mean everything, and I'll show you how nitrous oxide sometimes can be dangerous, but most of the time it's pretty safe. SIBO is a little bit higher, 3% metabolism to mostly fluorinated compounds. Volatile anesthetic hepatitis is usually caused by oxygen supply demand imbalance. Okay, that's another thing that's important in the sense that if you induce hypotension in somebody with a hepatic artery, the blood flow is only 25%, but it carries 50% of the blood supply. So if you drop that blood supply, it can significantly impact the liver's oxygenation status. Okay? If you put positive pressure ventilation, what happens to portal circulation? Does it increase or decrease? It decreases. Okay, because when you put positive pressure ventilation into the chest, it acts like the dam effect, and everything below that, which is the liver is right below the diaphragm, it gets positive pressure, so portal circulation begins to become congested. Okay, so portal circulation blood flow drops, which is another 50% of the oxygen is being delivered by that. So you're getting a double whammy effect when you give volatile anesthetics under positive pressure ventilation. What should be discussed with you more so is that if you allow somebody to spontaneously breathe on volatile anesthetics, their chance of having a liver problem is pretty low. Okay? But usually, if you're doing a big major operation, you have to convert them into mechanical positive pressure ventilation because you got to open the belly up or something like that, and that's where the problem becomes in these kind of disease processes. Patients can have prolonged surgeries where long positive pressure. They may be given PEEP in case. If patients also may have this, if you get a long case, what's the likelihood that you're bleeding? It goes way up. So transfusions may be also a problem. And in the old days, people used to argue back and forth, what is really causing hepatitis? And they would argue aggressively about it. Okay? It would be like a very significant discussion. Because a lot of times these people are getting transfusions, and their transfusions were what was giving them hepatitis C. And we couldn't measure it, so we were calling it, we don't know. Everybody said, well, it's the drugs, versus it was actually really hepatitis C that was causing the problem. Hypotension, I could just explain to you, and hypoxia is also a concern. You can also get drug-induced hepatitis from something so simple as acetaminophen. You know, you don't think of it, Tylenol. Who cares? Not a big deal, right? Well, I had a few years ago where somebody was having a lot of pain, and he was telling me that he was drinking a lot of Tylenol. I said, well, how much Tylenol is a lot? And that's a good question to ask, okay? And here's why. He was drinking 6 to 10 Tylenol at a time for 5 days, 3 times a day to 4 times a day. Okay? And immediately when I said that, you know what, I don't like that, and the guy's a little bit jaundiced, so we got liver function test, okay? And sure enough, he was actually toxic on acetaminophen. And we didn't take him to surgery, and we put him in the unit, and he almost died. If we had put him into the operating room and exposed him to anesthetics, positive pressure ventilation, bad things would have happened to this guy. Okay, so you got to sort of keep in mind with acetaminophen, it's not a joke. It's actually one of the most common causes of overdose and death in the United States from an over-the-counter drug. And it's one of those things that people don't think about. Okay? If you look at the new Tylenol bottles, how many people remember when the Tylenol used to be able to get it in a big jug? Okay, kids would pick that up and drink it like it was nothing. They would get toxic on it, and they wouldn't know. You know, they thought it was just like candy. Okay, so now the new ones are coming down. They're less than 100 tablets. They don't sell, I think, more than 100 tablets anymore. They're trying to restrict it so people don't have problems. Okay. What you get is depletion of glutathione, which is inability to conjugate toxins, and you get hepatocellular necrosis. The treatment is actually very simple. It's mucimist, which is N-acetylcysteine. And cysteine forms new glutathione for the patient, which acts as an antioxidant, the tripeptide. Differential diagnosis in postoperative dysfunction is, I'll stop there for now, and I'll come back and start at 11:25. Okay?